The topic for the seminar is Approach to a Case of Bleeding Disorder and DIC. The faculty for this slide seminar is our Dr. Rutvi Dave ma'am and Dr. Sukesh Nair sir. And next week on 27th of September, that is Tuesday, SGPGIMS Lucknow. So now I invite Dr. Tulsi Giver ma'am to deliver
opportunity to keep this talk. So I'll just share my screen now. CMC Vellore. So in this talk, I'll be talking about the basics of coagulation and the coagulation cascade with the current concepts. So you would all be familiar with this coagulation cascade, which I would like to call the textbook version, which has the extrinsic pathway and the intrinsic pathway. So the extrinsic pathway was coined by Robert McFarlane and the intrinsic pathway by Oscar Radnoff, both in the year 1964, almost simultaneously. So the extrinsic pathway starts with when there is exposure of tissue factor, there is activation of factor 7 to 7A, and 7A in turn activates factor 10 to 10A, and 10A in the presence of its cofactor 5 converts prothrombin to thrombin, and thrombin converts fibrinogen to fibrin. On the other hand, the intrinsic pathway starts with contact activation and activation of factor 12 to 12A, and 12A converts 11 to 11A, and 9 to 9A, and 9A in the presence of its cofactor, factor 8, activates factor 10 to 10A. The remaining part from 10A onwards is common for extrinsic and the intrinsic pathway and is also called the common pathway. Now, there were some problems which were raised or questions which were raised which were not explained by this coagulation cascade. Let me try to explain this by a case scenario. So this is a 45-year-old lady who was awaiting a CBG referred from Coimbatore by a cardiothoracic surgeon due to prolonged apatity, and this was repeated 3 times to confirm that it was prolonged. There was no prior history of bleeding manifestation. This lady has had 2 normal vaginal deliveries, which was uneventful. In our lab also, the apatity was significantly prolonged at 113 seconds. This is a reference range, and it was correcting completely on mixing studies with a normal prothrombin time, normal CPC, and bleeding time. So when you have an isolated prolongation of apatity, you think of deficiency of factor 12, factor 11, factor 9, or factor 8. So in this case, we proceeded with these factors. The 8 and 9 were normal, but the 11 was found to be undetectable, or it was less than 1%. So there was a mismatch with the patient's laboratory results and the patient's history. There was no history of bleeding manifestation in this 45-year-old lady. But the laboratory-wise, there was a significantly prolonged apatity due to undetectable levels of factor 11. So how do we explain this? I'll come to this case in a little while. So with a lot of questions or queries against this coagulation cascade. So let's try to go through it one by one. So you're all familiar with hemophilia A and B, which is deficiency of factor 8 and 9, which cause severe bleeding symptoms in spite of having an intact extrinsic pathway. So the question remains, why do these patients who have all the components of the extrinsic pathway form the clot through the extrinsic pathway alone? Why do they need an 8 and 9 for the formation of the clot? The other thing was the factor 12 deficiency does not have any bleeding manifestation, but factor 11 deficiency, like our case we saw, has variable symptoms. Like this lady that we saw did not have any bleeding manifestation, but sometimes even mild deficiencies or moderate deficiencies at 12 can have significant bleeding. So 11 deficiency has got variable symptoms. The questions which were not answered by this cascade were, Hegman's factor or factor 12 deficiency does not cause bleeding, but factor 11 deficiency causes variable symptoms, while factor 8 and 9 deficiency, just as hemophilia A and B, causes severe bleeding despite having a normal intact extrinsic pathway. So the answers started coming. So first it was found that now when there was exposure of tissue factor, the tissue factor activates factor 7 and forms a complex. So this complex is able to activate not only factor 10, which gets activated to form 10A, but also factor 9. So thereby we see that factor 9 can be activated with the help of the tissue factor 7 complex without the help of factor 12 or factor 11. A new protein which was discovered, which is called the tissue factor pathway inhibitor or TFPI. Now, as the name indicates, it inhibits this pathway. So what happens is, so once a tissue factor factor 7 complex forms, it activates 10 to form 10A. As soon as 10A is formed, it forms a complex with TFPI, and together it forms a quaternary complex and inhibits further contribution or extension of the extrinsic pathway. So to incorporate all these concepts and answer these questions, a new pathway, a new model for coagulation was proposed, which is called the cell-based model of coagulation, based on which all the coagulation process occurs on the surface of the cell. This can be the surface of an endothelial cell, platelets, or monocytes. And according to the new pathway, there are 3 steps: initiation, amplification, and propagation. So the initiation is what we saw before. So when there is exposure of tissue factor, so whenever there is injury, there is exposure of tissue factor presenting cell. So this tissue factor in turn activates factor 7. And the tissue factor factor 7 complex activates 10 to form 10A. And this 10A which is formed is going to convert prothrombin to form thrombin. Simultaneously, there is also activation of 9 to form 9A. Now, what happens to this 10A? The further extension of the extrinsic pathway is inhibited by the tissue factor pathway inhibitor. So at the end of the initiation step, there is only very small or trace amounts of thrombin formed because further extension is inhibited. So this is considered like a spark or like a matchstick in the fire. So it just initiates the coagulation cascade. And the small or the trace amounts of thrombin, which is formed in this step, is going to amplify the coagulation cascade. Now, how does it do that? So the thrombin which is getting formed is going to activate the cofactors of coagulation, which is factor 5 and factor 8. It is going to activate the platelet. As a result, the procoagulant surface of platelets are exposed. It is also going to activate factor 11. Now, when the cofactors 5 and 8 are activated, it is going to form two important complexes on the surface of the activated platelet, the 10A complex and the prothrombinase complex. As the name indicates, the 10A complex causes activation of factor 10 and the prothrombinase complex causes activation of factor 2. So the 10A complex is formed by the activated factor 8 activated by thrombin and the activated factor 9, which is activated in the initiation step, and the 10. So together, the 10A complex causes conversion of 10 to form 10A. The activated 10A will now form the prothrombinase complex together with the cofactor factor 5 to convert prothrombin to form thrombin. Now, this step is capable of generating large amounts of thrombin. So you see that in this step, so you realize the sheer importance of the factor 8 and 9 in the formation of the thrombin. The third step is propagation step. This is where the factor 11 comes, the role becomes important. So factor 11 activates factor 9, and 9 then forms the 10A complex and the prothrombinase complex, and prothrombin gets converted to thrombin, which converts fibrinogen to form fibrin and forms the clot. So the amplification step is capable of producing large amounts of thrombin and is sufficient for a clot to stop, unless you need a sustained propagation of the clotting process, especially in the postoperative state, when the factor 11's role becomes important. So the new pathway has got three steps: the initiation step, the amplification step, and the propagation step. So nowhere along this coagulation cascade of cell-based model did we see that factor 12 is involved, because factor 12 is not involved in the coagulation cascade. There is lesser role for factor 11, because we saw that the amplification step itself is capable of generating large amounts of thrombin. And we saw the sheer importance of the factor 9. That is why hemophilia A or B patient causes severe bleeding symptoms. And the cell helps to localize the clot formation, because the clot formation happens on the surface of the activated platelet. This helps to localize the thrombus at the site of the injury. So coming back to our patient, now if you see the factor 8 and factor 9 of this patient is not just normal, it is very, very high. So when the 8 and 9 is so high, in the amplification step itself, this patient is capable of generating sufficient amount of thrombin to form a clot. That is why this patient has never bled in her life and is never unlikely to bleed in the future with such high levels of factor 8 and 9. Let's see a cartoon which will try to show you how the clotting process happens in our body. So in the normal states in the vessels, you have a normal intact endothelium where the collagen, the tissue factor is not exposed, and you have the coagulation factors, the platelets, the warm filling factor, all in the circulation flowing smoothly. When there is a breach or cut or an injury, there is exposure of tissue factor. There is also output of blood and its components. Now you have to have something to stop the clot or stop the flow of the blood and form a clot at the site of the injury. So when there is exposure of tissue factor, now imagine that the blood in the vessel is flowing at a very high velocity. Okay, so platelets along with all these components are going to get carried out and cause the bleeding is going to continue. You need something to stop the clot, stop the platelets at the site of the injury. Now, this role is carried out by this protein called von Willebrand's factor. It is an adhesive protein, a large multimeric protein, which can bind spontaneously to collagen to its A3 domain. Now, normally in the circulation, the von Willebrand is seen in this coiled form with binding sites for collagen, but the binding sites for platelets, which is the A1 domain, is normally not exposed in the circulation. So, in the circulation, the von Willebrand factor cannot bind to platelet because its binding sites are not exposed. And collagen is not normally exposed in an intact endothelium. But when there is an injury and there is exposure of collagen, the von Willebrand factor has got binding sites for collagen, and now it uncoils or gets activated. So it can imagine like it's unrolling itself like a carpet, exposing its binding sites for platelets. So now the A1 part of the von Willebrand factor, which can bind to the glycoprotein 1B of platelet, is exposed. So now when the platelets are flowing, along with the flow of blood, the platelets get attracted to the glycoprotein 1, the 1B receptor is attracted to the A1 site of the von Willebrand factor. But this interaction is weak because the platelets will be carried forward by the flow of blood. But the von Willebrand factor is a large multimeric protein. So by multiple such interaction, the platelets roll over the surface of the platelet before it finally comes to adhere and gets activated. When platelets get activated, there are four changes which happen. Platelets are normally small disc-shaped structures. They appear pseudopodia and become spiculated sphere. This increases the surface area. Now, according to the cell-based model of coagulation, all the coagulation, the 10A and the prothrombinase complexes are going to form on the surface of the platelet. The more the surface area, more is the surface for the coagulation to occur. Next is a flip-flop mechanism. So normally in a platelet, the anionic phospholipids, which are the procoagulant phospholipids, are seen on the inner side of the platelet surface. So when a flip-flop mechanism happens, the anionic or the phosphatidyl serine are going to come to the outer surface of the platelet. So again, this is the surface. These anionic phospholipids are the surface on which the coagulation cascade, the 10As and the prothrombinase complexes are going to get formed. The 2B3A receptor, which is the platelet aggregation receptor, is going to get activated, and the platelet, which is rich in calcium and alpha and delta granules, are going to release granule, which is going to activate further platelets. But the large multimeric form of von Willebrand factor is very important because the initial interactions are weak because the platelets get carried away by the flow of blood. If the von Willebrand factor is not of the large multimeric form, it is not functionally active and platelet addition cannot happen. So when you have the von Willebrand factor of the large multimeric form, the platelets will roll on the surface of the vessel wall, finally get activated. When the 2b3 receptor get activated, it brings about two platelets together and forms platelet aggregation. So this process by the 2b3 receptor brings two platelets together with the help of fibrinogen as a ligand is called platelet aggregation. Now this results in formation of the platelet plug or the primary hemostatic plug. Now the primary hemostatic plug happens as a result of an interaction with the collagen, the von Willebrand factor, and the platelets, namely the glycoprotein 1b receptor of platelets and the glycoprotein 2b receptor of platelet, which is involved in platelet aggregation. Now, the platelet plug is a weak clot. Now, when you have an injury on your skin, you feel that there will be bleeding, but the bleeding stops in a few minutes or 5 minutes. But if you start playing with the clot, you realize that it can bleed again because this is not a strong clot. For the clot to be strong, it needs to be cemented by fibrin. Now, the platelet plug is the best platform for clotting process to happen because there is a lot of tissue factor at the site of the injury. The factors, factor 5, factor 8, fibrinogen, factor 11, are all present inside the platelet, which gets released when platelets get degranulated. But factors which are absent in the platelets are 2, 7, 9, 10. Now, 2, 7, 9, 10 are the vitamin K dependent factors. Now, what does vitamin K do? They have all got glutamic acid residues in them. Vitamin K causes gamma carboxylation of these glutamic acid residues, thereby increasing their net negative charge. So when they get increased negatively charged, they get attracted to the positively charged calcium ions. Now, in this coagulation cascade, you can, if you notice, wherever the vitamin K dependent factors are involved is where calcium is required for the activity. So these vitamin K dependent factors get attracted because of the negatively charged ions to calcium. When they bind to calcium, they attain now a net positive charge and they get attracted or bind to the anionic phospholipids. Now, where do you see anionic phospholipids? Now, we saw by the flip-flop mechanism that the anionic phospholipids get activated on the surface of the platelet. So the surface of the platelets, all these vitamin K dependent factors now come and rest on the platelets because they get attracted by the anionic or the anionic phospholipids on an activated platelet. The platelet plug is the best platform for clotting to happen because the activated platelets or the platelet plug ensure also very high localized concentration of calcium. So calcium is seen in the granules or delta granules of the platelets, which are again released when the platelets get activated. So calcium source comes from the platelet. And the procoagulant platelet, which is as a result of the flip-flop mechanism, the anionic phospholipids, the procoagulant platelets phospholipids are seen on the outer surface, and this will attract the vitamin K dependent factors and lead to formation of the tenase and the prothrombinase complex on the surface of the activated complex. So let's see how this happens. So factor 5 and factor 8 we saw are cofactors of coagulation. So when they get activated, now the vitamin K dependent factors get attracted by the anionic phospholipids on the platelet surface, and they come and slowly rest on the platelet surface. So when this happens, they find the binding sites. So the factor 9A, which gets activated for the initiation step, find the binding site on the cofactor factor 8, and the 10 binds to factor 8 and forms the tenase complex. Now this leads to activation of factor 10 to 10A, leading to cleaving of a binding site. Now once 10A gets activated, it loses its affinity for factor 8 and it gets attracted to factor 5 and forms the prothrombinase complex, which leads to conversion of factor prothrombin to thrombin. Now once thrombin is formed, it loses its affinity for factor 5 and thrombin will now convert fibrinogen to form fibrin. So now the platelet or the primary hemostatic plug will be cemented by the fibrin or the fibrinogen, which will lead to formation of a stable, strong clot. Now, this is about the coagulation cascade, and we saw the interplay between the vessel wall, the von Willebrand factor, the platelets, and the coagulation factor, leading to the formation of a stable clot. So when you're coming to the laboratory test for coagulation, why or when is a laboratory test for coagulation ordered? When a patient has signs or symptoms of a bleeding disorder, when the patient has had past history of bleeding or had a family history of bleeding, when a patient is to undergo invasive procedure as a part of preoperative evaluation, or to monitor anticoagulation therapy like warfarin or heparin, or to monitor liver disease. The aim of the test or the tests is not to miss any step that would put the patient at risk of bleeding. So when we talk about tests for coagulation disorders, you can test for the whole process as one test, which is not possible. Or you can test for individual processes, so test for the platelets, von Willebrand factor, coagulation factors, which is going to be very cumbersome. The best thing is to test it in small groups. So these are called screening tests. So you're going to test one aspect or certain aspect. You're going to test the extrinsic pathway by one step. So screening test is a preliminary procedure to detect the most characteristic sign of a disorder that may require further confirmation. Ideally, a screening test should be done in a short time with comparatively little effort, should be cheap, should be very sensitive, and serve as a selection procedure for further specific investigation. So can you name some screening tests for hemostasis? So you have the platelet count. Yes, platelet count is important because when you have decreased platelet count with thrombocytopenia, also puts the patient at risk for bleeding. You have the bleeding time. Now, the bleeding time is a screening test for primary hemostatic disorders, which can be either platelet function defects or defects of von Willebrand factor or von Willebrand disease. Then you have the prothrombin time, which is a screening test for the extrinsic pathway, or the APTT, or the activated partial thromboplastin time, which is a screening test for the intrinsic pathway. But above all, the most important screening test in hemostasis is the history. So how can history be used as a screening test? Bleeding occurs when there is failure of any part of the processes leading to a stable clot. And the bleeding manifestation or symptoms will vary depending upon how much or to the extent or the degree of this failure, and also on the defective phase. When I said there is primary hemostasis, which is components which lead to the formation of the platelet plug, and there is secondary hemostasis, which leads to the formation of the fibrin. So the primary hemostasis platelets is contributed by the platelets and the von factor, while the secondary hemostasis is contributed by the coagulation factors. So by the type of the bleed or the site of the bleed, you can come to know what is the. I'll just share my screen again. Okay.
Ma'am, your screen was not presentation was not visible. Now it's visible.
Okay. So based on the site of the bleed, like whether it is surface skin bleed and surface mucosal bleed are signs of primary hemostatic disorder. So surface mucosal bleed can be surface mucosa of the nasal membrane which presents like epistaxis, or it can be gum bleeding, hematuria, GI tract bleeding, or menorrhagia. So these are all mucosal bleed or can be considered as surface bleeds. Or it can be skin bleeds, which can present as purpura, petechiae, echinosis, or subcutaneous hematoma. So surface bleeds are a manifestation of primary hemostatic disorder, which can be due to defects in von Willebrand factor, platelets, either platelet function defects or defects of von Willebrand factor. While deep bleeds, like seen with muscle hematomas, or joint bleeds like hemarthrosis, are seen with secondary hemostatic disorder like coagulation factor deficiency. Hemophilia A or hemophilia B are classical examples. But there are certain symptoms which are very specific for certain deficiencies, like delayed wound healing, umbilical stump bleeding, or large hematomas inappropriate for trauma, can be seen with fibrinogen deficiencies and factor 13 deficiency. Now, factor 13 is involved after the fibrin is formed. It inserts cross-linking in the fibrin and stabilizes the clot. So when you say have patient with present umbilical stump bleeding, which is a very unusual symptom, you need to think of either fibrinogen deficiency or a factor 13 deficiency. Presence of any of these symptoms to an abnormal extent will identify a bleeder. Now, how will you know to what extent? So a patient with a mild bleeding disorder, how will you differentiate between a mild and a severe bleeding disorder? A patient with a mild bleeding disorder will have infrequent symptoms, will have had minor surgeries in the past which may not have had led to any bleeding manifestations. While a severe bleeding disorder usually presents spontaneous bleeding without any obvious provocation, which the symptoms will be more frequent, sometimes requiring a hospital visit. Now, in India, even one hospital visit can be considered as very significant because patients rarely come to the hospital. And also the extent and quantity of the bleed. Now, trivial epistaxis, nosebleeds can be a very common symptom which can happen to any of us. But the amount or the extent, the frequency of the bleed also identifies a severe bleeder. Now, any kind of blood transfusion which is required to replace a blood loss can be considered as a severe bleeding disorder. Before assessing the severity of the bleeding, you need to rule out secondary causes of bleed like gingivitis. Poor oral hygiene can also lead to gum bleeding. And because there is poor oral hygiene, there is pain, the patient will not brush his teeth properly again, which will be a vicious cycle and lead to more bleeding. Synovitis can be a cause for hemarthrosis, but epistaxis can be because of nose picking or can be because of a deviated nasal septum. So you need to assess before assessing or labeling the patient as a bleeder, you need to assess whether there are any secondary causes of bleeding which can mimic a frequent bleed. Now, to quantify or to objectify the history, the ISTH has published a bleeding assessment tool to improve the collection and reproducibility of the bleeding history. So according to which there are 14 categories of symptoms, and each symptom can be scored from 0 to 4, and a total score can be calculated. Now, based on your total score, like in children, a score of 3 or more is considered significant. An adult male, a score of 4 or more is considered significant. An adult female, a 6 or more is considered significant. So based on these scoring system, you can actually decide whether a patient who has come to you is a significant bleeder or not. For example, now you see this symptom of epistaxis can be scored from 0 to 4. So epistaxis can be considered significant only if the frequency is more than 5 per year, or even if one episode has lasted for more than 10 minutes. So trivial epistaxis, few streaks of blood, is actually no or trivial. Any blood transfusion takes it to a score of 4. Also, the treatment history becomes important. So if the patient has got history of transfusion, the patient has required a factor 8 or 9 concentrate transfusion, it suggests the diagnosis of hemophilia A or B. If the bleeding is arrested with particular blood products, it suggests deficiency of a particular factor. Like if the patient was bleeding stopped after transfusing FFP, it suggests a deficiency of coagulation factors. The next question that you need to ask is whether this is an inherited disorder or an acquired. How can you make that out? Based on the age of onset is early childhood, suggests a possibly inherited disorder. Also, you have a family history. So if the patient has got a family history of bleeding tendency, again, it suggests a inherited type of disorder. So how will you understand? The sex-linked recessive pattern is seen with hemophilia A or B. So in sex-linked pattern of resistance, the males are affected, the females remain carriers and may not be symptomatic, while the males, so you can see the history on the maternal side, the maternal uncle, the maternal grandfather will be affected, but the females will remain carriers and non-symptomatic. The autosomal dominant pattern of inheritance can be seen with von Willebrand's disease. Now, in von Willebrand, the most severe form is type 3, which has got an autosomal recessive pattern of inheritance, and most other subtypes have an autosomal dominant. And when you have a dominant pattern, we can see a very prominent history. We can see that there'll be significant breeding history in one of the parents in the family. Autosomal recessive, the parents are carriers and will be asymptomatic, and it is commonly seen in consanguineous marriages. So an abnormal coagulation parameter has no major diagnostic value if the patient is not bleeding, has not had any past history of bleeding, and not likely to be a bleeder. So it is very important to correlate a laboratory test with the history because it doesn't make any sense without history. So I'll just show you two case scenarios, and for these following cases, I will want you to calculate the BAT score for the patient to know whether this patient is a bleeder or not a bleeder. And I would want you to answer whether this patient is a bleeder or not a bleeder based on the BAT score, whether it is a severe bleeding disorder or a mild bleeding disorder, whether it is a primary hemostatic disorder or a secondary hemostatic disorder, if it's an inherited or an acquired disorder, and if inherited, what is the pattern of inheritance, autosomal dominant, autosomal recessive, or X-linked recessive, and what is the likely diagnosis. So this is the first case. This is a 33-year-old female with history of menorrhagia since menarche requiring hormonal therapy. She gives history of occasional gum bleed. There is also history of epistaxis lasting for more than 10 minutes for which she took consultation. Her father has history of gum bleeds and slight prolonged bleeding after trauma, and a paternal grandmother, that is her father's mother, also had easy bruisability and hematoma formation. She has two children and the pregnancy and the parturition period. She did not have any bleeding during her deliveries. So let's look at her first symptom. She's had menorrhagia, and she's had menorrhagia since menarche. So that will be a score of 3. And she's also had epistaxis. She's had epistaxis which lasted for more than 10 minutes, but she required consultation for the symptom. So we will score this patient a score of 2, the higher score. She's also had gum bleeding, which comes in the oral cavity, but it was gum bleeding was just present, which did not require consultation. So overall, this patient has a score of 6. The ISTH BAT score for this 33-year-old female is 6. Is that significant? Yes, it is significant for an adult female. 6 or more is considered significant for an adult female. So is this patient a bleeder or not? Yes, this patient is a bleeder. Is this patient a severe or a mild bleeder? So this patient is a mild bleeder because if you see the score, it is just borderline, and she's got symptoms, but none of them are severe enough for a hospital admission. None of them are severe enough for which require blood transfusion or plasma transfusion. So she's got a mild bleeding disorder. That she had a primary hemostatic disorder or a secondary hemostatic disorder. Now, if you see all her symptoms, menorrhagia, epistaxis, and gum bleeding are all related to primary or surface bleed. Or skin bleeds, all mucosal type of bleeding, surface bleeds. So that is a feature of primary hemostatic disorder. So she has got a mild primary hemostatic disorder. Is it an inherited or acquired bleeding disorder? How will you make that out? Whether the symptoms has been there since childhood. Now she's had menorrhagia since menarche. So around 12 to 13 years of age, she's been symptomatic for a long duration. She's a 33-year-old female. She's also had a family history where her father and her grandmother are symptomatic. So it's likely to be an inherited bleeding disorder. And if inherited, what is the pattern of inheritance? That is likely to be autosomal dominant because of strong family history in a father and in the grandmother. So what type of disease is likely to be? Now, when you talk about the primary hemostatic disorder with an autosomal dominant pattern of inheritance, you think of von Willebrand disease. Okay, so when we evaluated this patient, we found that the von Willebrand factor antigen and the functional assay, the RICOG, which was both reduced, and this was a type 1 von Willebrand disease. So with just a history, you're able to delineate and understand whether this is a bleeding disorder or not, and whether it is what type, the primary or secondary hemostatic disorder or not. There's one more patient who's an 11-year-old boy who's referred by ENT surgeon with 2 episodes of epistaxis. They evaluated, they did not find any local cause. There were 2 episodes of bleeding, one which stopped for 5 minutes and other did not require any intervention. There is no past history, no family history of increased bleeding tendency. If you need to score this patient, the patient has epistaxis, he's gone to an ENT surgeon for consultation, so we'll score him a score of 2. Is that significant? An ISTH BAT score of 3 or more is significant for children, so this is not a significant score for a child. He's not a significant bleeder. Now, is this a severe or a mild? It's definitely a mild. He's not had a significant, if at all it is a bleeding disorder, it is likely to be a mild bleeding disorder. And the symptom is primary mucosal type of bleeding, so primary hemostatic disorder. Now, at this stage in a child, it is difficult to say because the child is still young. So we cannot say whether it's inherited or acquired at this stage, but there's no family history in this, is not there. But he's still a child, so he could have just started with the symptoms. You cannot make out what is the pattern of inheritance. So it could be a mild platelet function defect or mild von Willebrand disease. When we evaluated him extensively, we did not find any hemostatic defect. Now, these are the patients, when you have a history which is not significant, is most of the time they turn out to be no intrinsic hemostatic defect. So with that history, we know that this patient is unlikely to have anything significant. So when you talk about primary hemostasis, is it interplay between the collagen, the platelets, and von Willebrand factor? So when I talk about platelets, I just don't want the platelets in good quantity, or I don't want a normal platelet count. I want the platelet to be normally functioning. So platelet function should also be normal. The platelet addition is a function of the glycoprotein 1b receptor, and platelet aggregation is a function of the glycoprotein 2b3 receptor. And platelet secretion, that the granules should be normal, the release of the granules should be normal. So platelet function should be normal. Von Willebrand factor should also be present in normal quantity and quality. Okay, it should be able to, it should be of the high molecular weight multiple as well. So when you talk about the test for primary hemostasis, the screening test for primary hemostasis with platelet count and morphology, the bleeding time, and the platelet function analyzer, and more specific tests. So when we talk about platelet count, so platelet count also becomes a screening test. So in certain platelet function defects like Bernard-Soulier syndrome, we can have thrombocytopenia, and morphology becomes important because Bernard-Soulier disorder, which is a defect of the glycoprotein 1b receptor, is also associated with thrombocytopenia and giant platelets like the one we're seeing on the right. Okay, so platelet morphology is also important. Now, bleeding time is a screening test for primary hemostatic disorder, either platelet function disorders or von Willebrand disease. So what is bleeding time? It is a time taken for a standardized skin wound to stop bleeding. And a standard skin wound is 2.5 to 3 millimeter deep and 1 to 1.5 millimeter wide, the same dimensions of a simple lancet. So this is a test which can be performed with even a simple lancet by the modified IVs method, provided you follow those specifications. You need to tie a BP cuff and maintain the BP at 40 millimeter throughout the procedure. Select an area on the volar aspect of the forearm, clean the volar aspect, and stab confidently. So it is a stab wound, it is not a prick wound, and you need to stab 3 times. Why do you need to do it 3 times? Because you assume that at least one of the wound should be a standard skin wound as per the reference specification. We stop the stopwatch when all the wounds have stopped bleeding. The normal reference range for bleeding time in our lab is 2 to 6 minutes, but you might have to establish your own reference range. So a prolonged bleeding time indicates deficiency in primary hemostasis. It can be a platelet addition disorder, like a defect in von Willebrand disease, or it can be a defect in Bernard's glycoprotein 1b receptor, which is Bernard-Soulier syndrome, or aggregation defect, like you see in Glanzmann's thrombosenia, or it can be granule platelet secretion defect, okay, or thrombocytopenia. Bleeding time will be normal in hemophilias and in coagulation factor deficiencies. The disadvantages of bleeding time may be many. It is time-consuming, it is operator variable, subjective, invasive, and so many. It might be insensitive to mild defects. Yes. So there was another screening test for primary hemostasis, which is the platelet function analyzer. So it is a whole blood based test. It is a 5-minute platelet function test, which tests the high shear stress flow system. So this is an instrument, and you have this disposable cartridges like you see on the left. So you just need to add saturated whole blood into this reservoir. The machine will aspirate the blood through a capillary membrane, and this capillary tube is coated with a biological membrane, and this membrane is coated with collagen or ATP or collagen or epinephrine. So these are platelet activators. So platelets are activated, von Willebrand factor is activated. So there forms a platelet plug at the site of the membrane and occludes the flow of the blood. The time taken for the blood to stop flowing is recorded as a closure time. So as you can see, it tries to mimic the physiological process of a primary platelet plug formation. So a prolonged closure time can be seen in von Willebrand disease or platelet function defects. Advantages: it requires only small amount of blood, very simple to perform. It's a quick test, 5-10 minutes, you can get your results. It is difficult to standardize and so on. But the most major disadvantage of PFA is that it's a very expensive test. One cartridge of PFA costs 1,500 rupees, which will not be feasible for a country like ours. And it is not very sensitive for platelet function disorders. So coming back to bleeding time. So is it really an obsolete test for patients with bleeding disorders? We evaluated more than 800 patients with primary hemostatic disorder, and we found that the sensitivity for the bleeding time by the IVs method is 100% for Glanzmann's thrombocytopenia, 85% for Bernard-Soulier syndrome, 68% for platelet secretion defects, and 63% for von Willebrand, and out of which the most severe type, the type 3, is 100%. So in a country like India, where majority of the patients present with more severe defects, bleeding time by the IVs method, if done as per reference specification, can be a very good screening test for primary hemostatic disorder, provided you know that it is non-specific. A prolonged bleeding time can be because of platelet function defects. It can be because of von Willebrand disease. So you need to do further tests to confirm your diagnosis. So what are the specific tests that you will need to do when you have a prolonged bleeding time or a prolonged closure time on a platelet function analyzer? You might need to do the von Willebrand factor assays. You might need to do platelet aggregometry studies, flow cytometry, and so on. A very simple test that you can do to diagnose Glanzmann's thrombosenia is a clot retraction. So if you add blood in a clotted tube or in a plain glass tube, you see that after some time the clot has formed and the serum has retracted. Okay. Now, if you see the picture on the right is a patient with Glanzmann's thrombosenia, but the serum is not retracted. So absent clot retraction is the simplest and the easiest test to diagnose Glanzmann's thrombosenia in the lab. Now, when you have suspected platelet function disorder, you need to do platelet aggregometry. The test is done on platelet-rich plasma, which is obtained by light spin of saturated blood sample. Now, when you compare a platelet-poor plasma, which is obtained after high spin of secreted whole blood, and platelet-rich plasma, the platelet-rich plasma is turbid. It will not allow light to pass through because it is turbid in nature when compared to platelet-poor plasma. Now, when you add a platelet agonist, and this agonist can be ATP, it can be epinephrine, collagen, or erythrocytin, there will be platelets get activated, it forms platelet clumps, and these platelets will settle down. As the platelets settle down, there will be increased transmittance of light, and this change in transmittance of light is plotted in a graphically, and based upon the pattern of the agonist to different pattern of activation to different agonists, you can diagnose your platelet function disorder. So classically, Glanzmann's thrombocythemia has absent response to multiple agonists and response only to ristocetin, while Bernard-Solier does not respond to ristocetin and responds to other agonists. So this is like a very reverse pattern. So GT doesn't respond to agonists but only to risto, and vice versa for von Willebrand disease. So this is a classical pattern that you see for Glanzmann's thrombocythemia. If response, the green represents the patient. There is response only to ristocetin, where you see an aggregation by disaggregation, while absent response to others. While in a Bernard-Solier syndrome, you see there is no response to ristocetin and there is response to other agonists. You can confirm your diagnosis using flow cytometry. Glanzmann's thrombocythemia is absent expression of CD41. So you can see that these platelets, which are represented in blue, are expressing only the 42B receptor, which is a 1B receptor, and it is absent expression of CD41 or the 2B receptor. So this is diagnosis as Glanzmann's thrombocythemia. And we see a Bernard-Solier syndrome. Again, the platelets are represented in green here because you can see the number of platelets are less because usually these patients have thrombocytopenia. And you can see that these platelets are expressing only CD41 and is not expressing 42B, which is Bernard-Solier syndrome. Now, coming to von Willebrand disease, you can divide them into quantitative deficiency or qualitative deficiency. I'm not going into the details of those. You can use screening tests for diagnosing as bleeding time, PFA, or APTT. In von Willebrand disease, you can also simultaneously see reduced levels of factor VIII. You have to do antigenic tests and also functional tests to differentiate between the different subtypes of von Willebrand disease. When we go to secondary hemostatic defects, these are all plasma-based tests, which has to be done on platelet-poor plasma in a 37-degree water bath. You add the activator. Manually, if you're doing, you do by the manual tilt tube method, and you check after adding the activator, you check for the clot formation. The time taken for the clot to form after the addition of the activator is recorded as your clotting time. Okay, when you're doing it manually, you need to do it in duplicates, and you need to take the average value of your duplicate values. Now, with the advent of automation, these tests can be done by semi-automated and fully automated coagulation analyzers, especially when your sample volume is very high. When you talk about a screening test for extrinsic pathway, I'm sure that you all know that it is a prothrombin time. It is a time taken by saturated plasma to clot in the presence of tissue factor and calcium. So tissue factor is a thromboplasm which is bound to its negatively charged phospholipid, and you need usually the PT reagent itself contains calcium chloride. You do need to add it separately, and this test for the extrinsic pathway. Now, how do you report a prothrombin time? You can either report to the patient time or the control time, or you can report it as a ratio, that is the patient time versus the control time, or as a percentage. So when you have a patient's time 3 seconds more than the control, or the prothrombin ratio is more than 1.2, you can say that your prothrombin time is prolonged. But the ideal way to report a prothrombin time is with the INR and with its reference range. So what is INR? So let me try to explain the concept of INR using an example. So what is prothrombin ratio? It is a ratio of the patient's prothrombin versus the control prothrombin. So this was a patient who was discharged after deep vein thrombosis. He was put on warfarin. He had a prothrombin ratio of 2.5 when it was measured at CMC. He checks, so he was discharged and he checks it at a local laboratory near his house, and the doctor finds that the prothrombin ratio was only 1.6. The doctor tries to increase the dose because he wants to maintain it between 2 to 3. So 3 days later, he was found to be unconscious. But when he checks again in the local laboratory, the prothrombin ratio is only 3, which looks normal. But when he comes to CMC casualty, he's found to have a CNS bleed and have a prothrombin ratio of 9. So what is happening here? The prothrombin ratio varies between laboratories depending upon the type and responsiveness of the thromboplastin in your PT reagent. So there are different PT reagents available in the market, and some are good and some are bad. And so, for example, if you have a same patient plasma and you have 3 different PT reagents, you will have different prothrombin ratio depending upon the sensitivity of your PT reagent. So how do you define sensitivity? A most sensitive PT reagent will pick up the mildest of deficiency and exaggerates the difference between different ranges of deficiency. That is, the PT will be prolonged even if the factor 7 is mildly reduced to 40%. And you can see that when the prothrombin time will be more when the factor 7 is 11% than when it is 17%. So that is a good reagent. But a least sensitive PT reagent will miss deficiency even when the factor 7 reduces to as low as 21%. There is no significant difference in prothrombin time when the levels are 11 or 17. So that is a bad reagent. So how do you know whether one reagent is good or bad? So International Sensitivity Index or ISI is a value that is assigned to each PT reagent, indicating the sensitivity of the reagent. The most sensitive reagent will have an ISI which is close to 1. So ISI reagent less than 1.4 is good, and it is preferred to use PT reagent with ISIs less than 1.4. So what is now INR, or International Normalized Ratio? So INR is normalizing the prothrombin time expressed as a ratio by incorporating the sensitivity of this PT reagent. How can you calculate it? INR is patient's prothrombin time divided by the mean normal prothrombin time whole raised to ISI, where MNPT, or mean normal prothrombin time, the geometric mean obtained from at least 20 normal individuals. So this is a standardized system of reporting patients on oral anticoagulation. Now coming back to our patient who was discharged, you can see that the prothrombin ratio at the time of discharge, in CMC, the ISI, the PT reagent is 1. So you have an INR of 2.5. But when he goes to the local laboratory, the ISI, the PT reagent is 2. So you have an iron prothrombin ratio 1.6. So 1.6 into 1.6, so the INR was actually 2.56. So he was actually within the therapeutic range. But because the report had given a prothrombin ratio 1.6, the doctor had increased the dose. And when he presented unconscious, he had a prothrombin ratio of 3 in the local laboratory. The INR was actually 9. So if you can see that when you report the values of prothrombin time in INRs, there is no standardized reporting between the local laboratory and in CMC. So that is why it is important to report the prothrombin time in INR. When we talk about the screening test for intrinsic pathway, it is activated partial thromboplastin time, which is a time taken for the saturated plasma to clot in the presence of negatively charged contact activator, phospholipids. Now, it is called partial thromboplastin because it does not contain tissue factor, unlike the PT reagent. Calcium chloride usually have to be added extra. It is not usually present in the reagent. A prolonged apatity indicates deficiency of factor 12, 11, or any of the components of the intrinsic pathway. So when you have an isolated prolongation of PT, it indicates deficiency of factor 7. When you have an isolated prolongation of apatity, it indicates deficiency of factor 12, factor 11, factor 9, or factor 8. While when you have a prolongation of both PT and apatity, it indicates deficiency of the common pathway, which can be deficiency of factor 10, factor 5, prothrombin, or fibrinogen. So when both PT and apatity are prolonged, you can do a thrombin time because it will pick up a fibrinogen deficiency. Thrombin time is the time taken by plasma to clot when thrombin is added, and this is the time taken for thrombin to convert fibrinogen. This will pick up fibrinogen deficiencies. When you have a PT or apatity prolonged, the next very, very important step is to do a mixing or correction study. It is very simple. You're going to mix your test plasma, equal volumes of your patient plasma with equal volumes of the pool normal plasma where all the factors are in normal limits. You're going to do an apatity, whatever time was prolonged, you're going to repeat the test. So what is essentially the pool normal plasma is replenishing the patient's plasma with the factor which is deficient. So if the prolongation in the PT or apatity is due to deficiency of the factor in the test plasma, then the normal plasma will provide the deficient factor when they are mixed together and will correct the prolonged time. But if the prolongation is due to inhibitor, which can be an antibody to factor or it can be heparin, the normal plasma will also be inhibited and the prolonged time will remain prolonged. So when there is correction of time, it suggests factor deficiency, while there is no correction, suggests that it is inhibitor. When do you say there is correction? When it comes within the reference range for your PT or apatity. That is when you say that there is good correction. Where can you see no correction of your PT or apatity? It can be because of heparin, it can be because of lupus, it can be because of factor inhibitor, or even fibrin degradation products or increased levels of D-dimers can also cause a no correction. This has got very important implications to therapy. Now, if you have a patient who is bleeding with a prolonged clotting time, if there's correction on mixing study in which the normal plasma supply the deficient factor, that will mean that if you give this or transfuse this patient FFP, which is nothing but normal plasma, this clotting defect that led to prolongation of the time will get corrected and the bleeding will stop. So if the prolonged apatity is correcting, that means you can give FFP to the patient. But there is no correction. That means there's no benefit of giving FFP because depending upon the cause of the prolongation and cause of the inhibition, you might have to give the relevant product. So you can do mixing studies with controlled plasma, which will tell you whether it is a factor deficiency or an inhibitor, or you can do mixing studies with selective plasma, which is plasmas which are deficient in certain factors, like 8 serum or absorbed plasma. Let's give an example of mixing studies with factor 8 and factor 9 deficient plasma. So you have a patient with abnormal apatity. So if this isolated abnormal prolongation of apatity, you think of a deficiency of factor 8, 9, 11, or 12. So if this apatity corrects with factor 9 deficient plasma and does not correct with 8 deficient plasma, your diagnosis is hemophilia A. The factor 8 in the 9 deficient plasma replenish the patient's factor deficient 8, which is not present in the 8 deficient plasma. And vice versa will happen with hemophilia B. You can also, if you do not have a lab, you have a lab which do not have 8 or 9 deficient plasma, you can still diagnose hemophilia A and B using adsorbed plasma and 8 serum. Adsorbed plasma is prepared by mixing pool normal plasma with barium sulfate. Barium sulfate will remove the vitamin K dependent factors 2, 7, 9, and 10. Okay, so the resulting plasma will be devoid in 2, 7, 9, and 10. You can use the 8 serum. So 8 serum is normal serum, which has been stored over 2 days, which has been kept at room temperature for 2 days. So over the period of 2 days, the labile factors, factor 5 and 8 will disappear. And in the clotting process, fibrinogen and factor 2 will not be there. So this is your 8 serum. So how will you interpret a case, or how will you diagnose a case using the mixing study with adsorbed plasma and 8 serum? So if you have a patient with bleeding and you have an abnormal prolongation of apatity alone with a normal prothrombin time, okay, you think of it can be because of either factor 12, 11, 8, or 9. You're mixing with adsorbed plasma. Okay, now adsorbed plasma is devoid of 2, 7, 9, 10. Okay, but it has factor 8 in it. So when you mix with adsorbed plasma, there is normalization of the apatity. That means there is something in the absorbed plasma which got corrected in the mix and the apatity became normalized. But when you mixed with the 8 serum, there was no correction. That means there is something which is not present. So the deficient factor was not present in this. So there is correction with absorbed plasma and no correction with 8 serum, suggestive of a factor 8 deficiency. Similarly, you can do this when you have both PT and aperitif prolongation when you think of a common factor deficiency. So when you have both PT and aperitif prolongation, you think of a factor 10 deficiency, factor 5 deficiency, or a prothrombin deficiency, or fibrinogen. Here, but thrombin time is normal, so it is either of these 3 factors, 10, 5, or prothrombin. So it is on mixing with adsorbed plasma, there is no correction, while on mixing with 8 serum, this is correction. So this is because the factor 10, which is present in 8 serum, has corrected the patient's plasma. But factor 10 is not present in the adsorbed plasma because it is a vitamin K dependent factor. By using these combinations, you can actually diagnose which factor is deficient in your patient, and then you can specifically assay the particular factor which is deficient. That is important because you need to classify your patient as severe, mild, or moderate. Severe is when the value is less than 1%, moderate is when it is 1 to 5%, and mild when it is between 5 to 40%. The one aspect of coagulation factor which can be missed by a thrombin time or an APTT or a thrombin time is your factor 13. Now, once the fibrin is formed, factor 13 introduces cross-linking of the fibrin polymer and stabilizes the clot. In its absence, the clot is unstable and will first lysis, but this patient will have a normal PT and APTT. So this is a simple screening test. It's called a urea clot solubility, where the fibrin so fibrin is held by weak forces till factor 13 introduces bonds between them, but these clot which is formed in a factor 13 deficient patient will dissolve in a low ionic strength solution. So you induce a clot and you put it in a 5 molar urea solution and leave it overnight. If there is 13 deficiency, the clot will get lysed. So this is a screening test for factor 13 deficiency. Now, over a long time, I hope I have not confused you. So just to summarize what I've covered so far. So in the beginning, I talked about the normal physiology of coagulation. I talked about the cell-based model of coagulation, the interplay between the vessel wall, the platelets, the warm delivery factor, and the coagulation, all happening on the surface of a cell, localizing the clot to the site of the injury. These three are the key to understanding and diagnosing patients with bleeding disorder. Without any symptoms, an abnormal coagulation test result has no value. And with a good history, as you saw in some of the cases, you may just need the basic test of hemostasis for diagnosis. So when you have a history, you have your screening test along with a history. So a disorder for primary hemostasis, you can identify by history also for the presence of surface skin and mucosal type bleed. The screening test for primary hemostasis is platelet count, skin bleeding time, and a closure time in the platelet function analyzer. While the screening test for secondary hemostasis, history-wise, they usually deep bleeds like hemarthrosis or muscle hematomas. You have a prothrombin time to screen for your extrinsic pathway, APTT to screen for your intrinsic pathway. When you have a prolonged PT or APTT, you do mixing studies with controlled plasma and also with selected plasmas to identify the factor which is efficient. So you can identify the particular factor, assay it, and classify the particular patient. Thank you. That will be the end of the presentation. I will be happy to take any questions again.
Thank you, ma'am, for this comprehensive presentation and making this topic simpler for all of us. So now I invite Dr. Sukesh Nair sir for his expert comments.
I mean, I would say that there is hardly any comments because Tulsi has covered most of the points. If there are any questions, I'm sure we'll be able to take that.
Okay. So
I think there are some hands being raised. Yeah.
Yes. So in this is Dr. Rifat has referred to case number 1. She has asked why factor levels of 8 and 9 are more than the normal levels.
So it is possibly it's possibly intrinsic to the patient that his factor 8 and 9 are low. Like certain patients have, particularly in India, we see that the factor 8 levels are on the higher side, but this patient's factor 8 level is very, very high, making him actually, if you see it, it's even considered as a risk factor for thrombosis also. So yeah, it must be inherent to the patient.
Okay. And Dr. Mohammad Rabani has asked what do you think about simple bleeding time is helpful for von Willebrand disease screening?
Yes, definitely. So we have been doing bleeding time for all our patients who present with bleeding, and it is definitely very sensitive, especially for the severe bleeding disorder. And in India, most of the patients actually present with more severe bleeding disorder. So as I showed you, we have got a sensitivity of 60 to 70% for bleeding time for von Willebrand disease, and it is 100% for the type 3 von Willebrand, which is the most severe form. And most of our von Willebrand is actually type 3 von Willebrand disease, and it is very, very useful for von Willebrand disease screening.
I think as Dr. Tulsi very clearly mentioned, those who have history of bleeding, when you do a bleeding time, it helps identify von Willebrand disease if the patient has got von Willebrand. But history of bleeding is the most important thing. You don't do bleeding time on patients who don't have history of bleeding.
Dr. Naved has asked, how will you suspect a case of dysfibrinogenemia and what's the test for that?
Okay, so when you have a dysfibrinogenemia, usually the patient can have a very variable symptomatology because some patients can bleed and some patients may be even at risk for thrombosis. So usually you have a prolonged thrombin time, okay, and you have a fibrinogen activity. The functional assay by the modified Claus method will be reduced, while the antigenic assay will be normal. So you have a discrepancy between your functional fibrinogen assay versus the antigenic assay. That is called dysfibrinogenemia. So it can be dysfibrinogenemia or hypodysfibrinogenemia. So hypo is when the antigen is low and there is also a discrepancy between the functional and the antigenic assay. In both these scenarios, you usually see a thrombin time which will be prolonged.
One more question is there. Dr. has asked as mechanisms of coagulation, extrinsic as well as intrinsic. She has asked out of these two pathways mechanisms, which of these occurs on the surface of the cells, and what happens to the other pathway?
So I would not want to label this as extrinsic and intrinsic because according to the cell-based model, maybe you can say that initiation step. So initiation step also happens on the surface of the tissue factor presenting cell. So it forms like similar to the tenase complex, there is extrinsic tenase. Okay, so the extrinsic tenase is formed by the factor 7, the tissue factor, the factor 7 and factor 10. So that is the extrinsic tenase which will activate 10 to form the tenase. So intrinsic tenase is formed when there is activated factor 9, 8 and 10. So both these are formed on the surface of a cell only.
Okay.
Okay, there's one question about do you get giant platelets in glasnost thrombocythemia? Glasnost thrombocythemia is classically defined as normal platelet morphology. There is no platelet anisocytosis. There is no platelet until unless a patient who has got glasnost thrombocythemia develops antibodies, and therefore there will be thrombocytopenia, and that will result in giant platelet. But classically, glasnost thrombocythemia will have normal platelet morphology.
And sir, related to this question, one Dr. Jitsan has asked, is there is any difference between the macroplatelets and giant platelets, and presence of how many such giant platelets is significant?
Okay, generally there is a definition for giant platelets and large platelets. So giant platelets are defined as platelets which are larger than red cells, and large platelets are those which are beyond physiological anisocytosis. So usually when there is peripheral platelet destruction, the platelets can become large, but they don't become giant. Giant platelets are generally constitutional disorders like Bernard-Soulier syndrome, May-Hegel anomaly. So, but of course, if you look at the platelet histogram, it will reflect the presence of these platelets. But, you have to understand that there's a huge difference between giant platelets and large platelets.
There is one question by Dr. Kabya. She has asked to requested to explain about the ristocetin assay in von Willebrand disease.
Ristocetin is basically an antibiotic that was described many years back. The same time was almost the same as penicillin, but they banned the antibiotic because it was causing platelet aggregation. So what ristocetin does to von Willebrand's factor is that, like Dr. Tulsi explained, the von Willebrand's rolls out. It's normally von Willebrand's is actually rolled up, but when it's activated or when it gets exposed to something that activates, it rolls out like a carpet, and then it exposes the binding site for the platelets. So what ristocetin does actually is to roll out the von Willebrand's factor, and therefore platelets start binding to it, causing platelet agglutination first. Of course, once a platelet agglutination is a process of interaction between platelet and von Willebrand's factor through glycoprotein 1b, the platelets will get activated and then it will be followed by aggregation. So ristocetin will cause agglutination followed by, not agglutination, platelet binding to von Willebrand's factor followed by, which looks like agglutination followed by aggregation.
Okay.
Usually you don't see giant platelets in ITP, you see large platelets. But there is a difference between large platelets, large young platelets, stress platelets. There are so many definitions for large platelets, but usually they're not larger than red cells. And there was one more interesting question I saw. Role of ROTEM.
Yes, sir.
Yeah, role of ROTEM, ROTEM is like any other coagulation test, like PT and APT. So only thing is it brings in the role of platelet clot attraction, little bit of fibrinogen function. Yeah, but thing is, if you look at the APT, there's something called waveform analysis. So global hemostasis test will have some role, but I don't think so. ROTEM really makes a huge difference compared to ordering PT and APT.
Thank you, sir. I couldn't understand. One question is there from Dr. Mithun. How will you diagnose von Willebrand type 1C? Twice and I couldn't get the question. So
Vicenza is usually because of rapid clearance of the von Willebrand's factor.
okay.
Generally, classical Vicenza, you will find antigen will be very, very low. But when you do the REPA will be positive. That means there is enough ultra large high molecular multimers present to create a platelet aggregation during REPA. Sometimes Vicenza can show platelet aggregates in the peripheral smear.
I think according to the recent guidelines to diagnose Vamsi, we'll need the desmopressin trial.
Questions?
Yeah. Desmopressin trial is probably the easiest way to pick up Vicenza.
Increase clearance.
Yeah.
Any more questions which I might have left out? I don't see. So there are no other questions, and the attendees are thanking the ma'am and sir for their comments. There are no other questions, so we can end the presentation. So,
Thank you, Dr.
So,
Asha.
just a reminder to all our attendees. So the upcoming talk next Thursday on 22nd September will be a slide seminar. The topic for the slide seminar is approach to a case of bleeding disorder and DIC. And the faculty for this slide seminar are Dr. Rutvi Dave and Dr. Sukesh Nair sir from the Department of Transfusion Medicine and Immunohematology, CMC Vellore. So I thank all our viewers for attending today's talk.
Thank you. Thank you, Dr. Asha. Thank you.
Okay, thank you, ma'am, and thank you, sir.
Right. Thank you.